جت؟
حلو
كويس؟
زي الفل.
اوكي طيب انا ما اعرفش مين بيشخبط، انا مش هلبس الكلام خالص. دلوقتي ده فراكشر تيبيا لور ثيرد شورت اوبليك الاي بي وفي اللاترال. تحبوا اول حاجه دكتور عبد الحكيم تحب تعمل له حاجه تانية العيان دوت ولا
معلش يا دكتور ظاهر انا اسف، في الاوبشنز فوق فيو اوبشنز في you have to yes more options اوكي stop participant annotation عشان يبطلوا التعليم على الشاشه.
show name of annotator disable attendee annotation ماشي.
yes disable yeah thank you.
اوكي تمام. طيب دكتور اسامه، خلينا دكتور اسامه.
ايوه
ايه رايك في الكسر زي ده لو جالك؟ اولا محتاجين نعمل حاجه تانية،
محتاجين نشوف جوينت اباف وجوينت، عندنا الجوينت بيلو. بعد كده الحاجه الثاني انا يعني تحت الانكل مش شايفه كويس، عايز اشوف فيه احسن من كده. I would like to see the extension of the fracture if there is another articular fracture or not.
Okay.
We can ask for CT scan to see the fracture better than the plain X-ray regarding the ankle joint.
اوكي تمام. طب هل بتعمل سي تي سكان في لو هو fracture simple fracture tibia كده do you need a CT scan or not as a routine?
No, if there is no suspected articular fracture like this, X-ray of the leg with joint above and joint below will be adequate because I cannot see the extent of the leg proximally. We have a proximal fracture of the fibula. I would like to see the extent of the this fracture proximally. So the adequate X-ray joint above and joint below.
Okay, so as you have said, the joint above, joint below, plateau موجود, مفيش أي extension. As you have said, there was suspicious of something in the ankle, so a CT scan was done, and that was what is found. There was a small fracture posterolateral.
I would like to ask about the soft tissue condition.
Soft tissue is okay.
Neurovascular.
The patient neurovascular intact. Soft tissue it is not tense. It's lax, more or less lax. But for me, when I get a high energy trauma, I usually wait for. There is no urgency to do the patient, and usually I wait for the second day. Because sometimes there will be some edema and bully that happens within after few hours from the injury. So usually I wait for some time. But let's say here the skin condition is okay and the patient is now ready to be operated upon. So the first question is, would you manage it with an absolute stability or relative stability? What will be the sequence of reduction and fixation and the approach you are going to use? So who else can answer me?
We've got on the panel Dr. Sharif Khalid, Professor Sharif Khalid.
Okay. On
our panel.
Okay.
Sharif?
Mute him.
I muted him already.
موجود.
Sharif?
So someone else.
Okay. خليف.
محمود.
بدران.
دكتور خليف.
حد يحب من الاودينس يشارك معانا؟
يرفع ايده ويريز هاند ونشوف كده نسمع اسئله. نسمع.
معانا محمد بدران اهو.
اوكي. حد يرفع ايده كده لو سمحت.
اوكي. اوكي. محمد بدران. It's very difficult to find.
في دكتور محمد نشأت. دكتور محمد نشأت.
دكتور محمد نشأت raise your hand please. في 15 واحد raise their hands.
ايوه طلع واحد.
lower your hand يا معلم. انت lower your hand. طيب I don't know. Raise your hand again.
عشان ما نضيعش وقت يا طيب.
طيب.
دكتور خليف.
احمد خليف. ايوه unmute يا احمد. ايوه كويس كده. 1 second. يس دكتور احمد خليف اتفضل.
ايوه مساء الخير. الحمد لله.
اوكي.
كنت احاول اتكلم مش عارف. اوكي. Okay, so we have got two separate entities. We have got an intra-articular fracture of the ankle and oblique diaphyseal fracture. For intra-articular fracture, I think the concept is clear. We need anatomical reduction, which is easy because it's not displaced so much, and absolute stability. And because here it looks like here this is a fibula, so it is the posterolateral part of the tibia. So we need to get the screw either from posterior to anterior or from anterior to posterior. It's according. For me, it's easier, of course, to go from here and to get it from here. If I had to deal with the fibula, maybe I would use the posterolateral approach, but the fibula here is okay. So I might be going for an anterolateral approach to avoid so much dissection. But I need to be perpendicular on the
دكتور احمد دكتور احمد بغير يعني انت قصدك لو انا كان عندي فراكشر فيبولا كنت اثبت ده معاه من بوسترولاترال.
لو كان معايا فراكشر فيبولا وعندي بوسترولاترال فراجمنت هنا انا كنت اخش ان البوسترولاترال ابروتش اثبت الاثنين مع بعض.
لان هتديني انتاكت جو فروم انتيريور تو بوستيريور.
هنا you have one of two options. You go from anterior to posterior. هنا it's easier to go anterolateral approach لان posterolateral approach هنا هتفتح من ورا وجنب الفليكسور هاريسس لونجس والنيوروفاسكولار باند is not far away from here. وفي نفس الوقت انت you don't have to do a reduction. It's just a stabilization هنا. I think it can be a good option by anterolateral.
اوكي.
For the yes.
طيب انا دلوقتي ببص على الشات. انا جالي كذا اوبشن ان هم طبعا بيثبتوا الديستال تيبي الانكل ديستال تيبيا برضو سواء بالانترولاترال او بوسترولاترال ويثبتوا التيبيا سواء بنيل او ببليت. طب هو نيل او بليت تفرق يا دكتور احمد؟ تحب انت تثبته لو احنا التيبيا نفسها تثبتها ببليت ولا بليت؟
بص يعني هو هنا according to the method you prefer to stabilize. هي دي ممكن تكون it's like a spiral fracture or simple spiral fracture. ما فيش
long oblique ده long oblique
fracture or spiral fracture. So absolute stability can be achieved and relative stability can be achieved. It's according to your preference. أنا شخصيا أنا في الدايفيزيال fracture هنا I would go for a relative stability. أنا ممكن أعمل نيل.
اوكي.
يعني I can.
طيب دكتور أشرف. شريف خالد معانا دلوقتي مش كده؟
شريف بيسالك.
دكتور اخيرا انا انميوتد برضه.
طيب اوكي. احنا قلنا انت مشيت وسبتنا.
لا انا قاعد احاول.
طيب وايه رايك خلينا عشان نضيع. ايه رايك تعمل لها تخش ريلاتيف ولا تعمل ابسولوت؟
لا يعني هو according to most of the evidence relative زي ما دكتور احمد قال interlocking nail would be a good option. وفيكسيشن اوف ذا ديستال ارتيكولار فراكشر بابسولوت ستابيليتي ممكن تبقى 2 سكروز او a very small plate من بوست.
انا هسأل سؤال كده ليا انا بقى. يعني انا بالنسبه لي لو في simple fracture if I have a simple short oblique long spiral why not and I have a good fracture surface why not go for absolute stability.
ممكن تاخد 2 لاج سكروز ونيوتراليزيشن بليت it would be an accepted.
بالظبط كده خصوصا في السيمبل fractures.
هقول لك حاجه. العيان ده عنده كام سنه؟
he's a young adult.
طيب young adult would you يعني I think most of the evidence برضو would prefer this patient to weight bear as early as possible. فانت لو حطيت intramedullary nail especially حاجه زي الاكسبرت nail في سكروز كتير فوق وتحت this would allow the patient to weight bear immediately.
So it is about early mobilization not about
لكن الاثنين will achieve healing في الاخر.
same results. اوكي.
Yes.
هو
Yes.
طيب
يمكن انا
اتفضل.
ليا راي ان لو كان ما عنديش الارتيكولار فراكشرز البيلون فراكشرز
مهم.
كنت مثلا اجو فور نير ستريت عشان
اوكي
الايرلي ويت بيرنج.
تمام.
بس لو انا عندي البيلون ده ومش هخليه يعمل
مش
ويت بيرنج،
اوكي
يمكن البليت ستيل يبقى فاليد اوبشن.
اوكي. هو في برضه حاجات اجينست نيلينج، مش اجينست نيلينج، يعني في ساعات some consideration
If
بيقول
possible
لك
يا جماعه we've got some attendees from Kenya, Nigeria, Holland, and
okay.
Pakistan. If you can
So,
use
yeah,
English.
if you want to ask them, if they can, do they want to reply?
Yes,
You
okay.
want
You need English, يعني?
Yes, more English, please.
Okay.
Okay.
So another problem with nails, it is not a problem. Sometimes it should be considered. I don't know your experience about this. Those who are used to have a lot of kneeling, they go on their knees a lot. Does a nail make a difference for them, or because we have a lot of complaint from the entry point from those who do kneel a lot? What do you think?
I think if you do proper seating of the nail, you do just go on the side of the Achilles tendon, not through the Achilles. Not the
Achilles, patellar tendon.
The patellar tendon, and you just makes your nail, just the tip of your nail is well embedded inside. This shouldn't be much problem in this.
Okay, yeah, but sometimes you see it. دكتور حازم بيه، دكتور ايه رأي حضرتك؟
والله انا شايف انه all the given options are valid. All the given options are valid, لكن you are omitting some values in each option, or some points in each option. In the option where we can do anatomical reduction and interfragmentary compression, I think we should think about doing it percutaneous.
Okay.
By minimally invasive technique under image control, we try to reduce this fracture closely and use the Weber pointed reduction clamp or matte reduction clamp with two ballpoint ends. And we manipulate this. It will need some kind of skill in the manipulation in a form of traction, rotation of the distal fragment until the spike proximal will be seated or will hitch in its groove. And then we can close this by, we can close the gap. Is my marker apparent on the screen?
Yes. Yes, sir.
Yes.
So we can make a small incision using the tissue protector, and then we can pass by our leg screw in the ordinary way, gliding hole and then thread hole and so on. After doing this, through this minimally invasive technique, we can make sure that everything has settled here, and then we apply MEBO technique by a long plate, maybe a distal tibial plate, if you want to have a longer purchase with a good long working distance of the plate. This is one of the ways I would think I would choose this to operate this case if I could achieve this kind of anatomical reduction first. The second point of having a kind of intramedullary nail here is also a good option, but here, if you have a good look, it's at the junction between the tapering. The narrow end of the bone and the flare of the distal part. And in this instance, always we get kind of difficulty in reducing the distal fragment in a kind of closing the gap. So if we are using intramedial nail, we have to make a good reaming of the proximal part, so we can have a wide, maybe 9 millimeter diameter, or maybe 10, to pass it through the tibia. And we have to use the reconstruction. We have to use the smart nail, so we can get a good fixation, and we can use the fixation for avoiding any kind of malalignment of the distal fragment. So it can work both ways.
Exactly, it can work both ways. So,
both ways, but we have to see the best biological considerations of each one of them.
Okay.
To open it completely and to make a kind of interfragmentary, open interfragmentary screw and the plate, this is not a good option here in this fraction.
Okay. So,
Dr. Zahar,
document.
Yes, we have here an intra-articular fracture with a non-contiguous fracture of the tibia. So here, both options of plating is accepted, and intramedullary nailing with blocking screws and fixation of the articular surface is accepted. The comparison between the two, however, I found it only in one paper published 2017 in Acta Orthopedica Traumatologica Turcica in Turkey, and it compared the intramedullary nailing for simple articular fracture 43 C1 and C2, as well as MIPO. They had, I think, 37 patients intramedullary nailing and 36 MIPO fractures, and both had successful functional results. So they said that both techniques were successful in treating the patients. However, be aware of the valgus malunion in cases of intramedullary nailing, and be aware of recurvatum in the MIPO group. So if you're doing a plate, you have to check the lateral view often. And if you're doing a nail, you have to use blocking screws to avoid valgus.
Okay. So let's proceed كده عشان ما نضيعش. Let's proceed. So what is the thing? So let's
we want from you a resume, and a conclusion.
Okay, yeah. So about this discussion and what we have discussed, that is a simple fracture. We can have an absolute stability. Of course, we need to fix the articular surface first, and with an absolute stability, and then we go for the tibia, whether with the relative stability, whether with the absolute stability. Both techniques will give the same functional results, but at least we have to do it right. And as Sharif have said, we have to double check about any deformities that can occur either with a plate or either with a nail. So that's the conclusion. So let's see what's happened here. So as we have said, Khalif said, we did an anterolateral, small anterolateral incision, and we fixed the articular surface with temporary fixation with the K-wire, followed by leg screw from anterior to posterior. And it's on the lateral side to fix the segment. Then a very small incision on the fracture site was done. As you can see here, there is a needle to mark where is the fracture exactly, and very small incision was done. And we applied external fixator, one plane to maintain the reduction. And we did just a compression with a pointed forceps, and we applied a leg screw, and then we did plate with a MIPO. And here is the question: is do we need to bend this plate or not, or we put it as that's a locked plate? So do we need to bend it and just go through, or we put it as it is? Because bending with a locked plate, it can damage the holes. So what do you think about this?
You can put it as it is, as it's
as it is.
It doesn't have to be really touching the bone.
Okay, Ahmed.
هو
unmute يا اشرف. خلي البانل unmuted يا اشرف.
panel should be unmuted but unless they
ما خليف انت واضح انك بتقفل كل شويه. طب اسامه خليف، اسامه فاروق، اسامه معانا ولا برضه؟
اسامه
طب عشان ما اضيعش وقت.
انا
اوكي.
The plate, I think it is very important, like the two contouring with the plate. Then what the surface we are using to put the plate on is not going to match with the surface of the tube. Plate to be contoured with the surface of the tube because you are doing it now.
So your recommendation is to bend the plate, contour the plate. Okay. So here is the answer of our question. So if I am going to put a plate, a long plate from distal to proximal, and if it is still straight like this, that's what happens. Okay, it will end by pushing the distal fragment laterally, and the union it will lead to valgus. So it is recommended that at least for the sake that we need to contour the plate at least proximally and distal to avoid this varus and valgus position. And that's another example: fractured tibia, simple fractured tibia, and the surgeon decided to put it as it is straight. And as you can see distally, the distal segment, it's about what is the flare of the distal tibia, and it ended by valgus deformation. So that's why it's better if you go down to at the upper end, the distal end, to contour the plate a little bit. So the other question now.
Mahmoud Badran is speaking. Can I ask a question?
اتفضل دكتور محمود، بس سهل السؤال، سهل عليا. انت انا حبيبك.
لا يا باشا، حبيبي يا باشا. Do we need to open at the fracture site in order to reduce?
No, we don't need.
Yeah.
No, that's.
We can do the anatomical.
Exactly. أنا حطيت الإكزامبل ده عشان حاجة صغيرة. Don't hassle برضو في إنك تحاول تعملها closed وأنت مش عارف. افتح فتحة صغيرة. Do a mini open and حاول to preserve the soft tissue and you'll get the same result. بس أنا حاطط بالظبط كده ليه؟ عشان ما نقعدش نخوف الناس from open reduction. Okay. So that's about the bending. So another question which is very important here: do we need to twist the plate or not? نفتح بقى على دكتور أسامة فاروق كده. دكتور بدران.
مفتوح بس.
بدران. محمود بدران. Do we need to twist the plate?
Yes.
ولا لا؟
I think yes. If the plate distally is going to be on the medial malleolus,
okay,
we need to twist the plate. Otherwise, a malrotation is going to occur.
How much do we need to twist? How much twisting do we need?
Just only for the last two holes of the plate.
How much?
Just only for the rotation in order to be anatomical.
About 10 degrees, Dr. Zahir. About 10 degrees.
Exactly. So that's that's the problem with twisting. So that's fractured tibia, and this is the patient. This is the graphic. So if you are going to twist, okay, here it ends by rotating the limb, the whole limb, unless you put it, as Mahmoud said, you put it distally at the flare of the medial malleolus. You have to twist it for 5 to 10 degrees, sometimes 15 degrees, but that's the only indication to twist the plate. If you are going to reach the medial malleolus, it's better to twist it for 5 to 10 degrees. Okay, so there's another case in which they have. So that's our. Let's go back to our case. That's what they did. They put a leg screw, and they did a minimal invasive plating, and 2 screws above and 2 screws below, and they put him in as you can see, they have put the patient in a cast, and that's the picture after 28 weeks. It is fully united with no callus formation, and this is what we call it absolute stability. We got it. There is compression and ended with an absolute stability and no callus formation.
Excellent.
I
so that's
Would you like to address the ankle stability after fixing the tibia before leaving the operative theater when we have a proximal fibular fracture like this and third malleolar fracture to test ankle stability and syndesmotic ligaments as well?
احنا عندنا هنا خبير القدم الفوت expert هنا. He can ask his question. He can answer you. What do you think?
I totally agree with you, Professor Sam, because this kind of injury, you've got a multiple level injury. So you have got a fibular injury higher up, and then you have got a fracture of the junction middle and lower third of the tibia, and then a fracture of the distal end of the tibia. It means that the force has been distributed along the whole leg from proximal to distal. And with a force with this magnitude, I would think that it is like a rotational force, and you can see it from the pattern of the fracture of the fibula, the spiral or the oblique pattern of the tibia. So definitely you cannot exclude this rotational effect to have an influence on the interosseous membrane or the ankle ligament. So definitely I agree with you, Professor, about the ligament before going out, because you might need something to be done.
Thank you very much.
Thank you for eliciting this.
Okay, so let's shift to the summary of this case. Any tibial, for any joint, any diaphyseal fracture, we need to have a joint above and joint below. CT scan is needed if you are in doubt if there is an extension. X-fix sometimes is used for an indirect reduction. It can maintain your reduction and it can help you very much in the reduction technique. Here we have used the leg screw as a compression, and then we have applied the neutralization plate to protect our leg screw. Okay, so let's shift another, the same fracture. It's exactly the same fracture. This is long, short oblique with the same, and it has a small fracture. This posterior tibia is the same, and here we did a nailing. Okay, and exactly the same. We have fixed the distal end of the ankle, and that's a nail. And at but the end of the nail and healing after 15 weeks, we get a lot of callus formation, and that's what's called, we call it relative stability that we get from the nail. And this after 30 weeks, and we get the same results. Of course, we can debate about the benefit of nail and plate. Definitely, mechanically, nailing is much better, definitely. But sometimes we can put...
You didn't need to put the patient in a cast in this after you put the nail.
Yes, exactly. There is a lot of potential from nailing. And as Sharif have said, if you are going to put a nail, you have to make double check about the valgus and varus instability, and sometimes you need to put a blocking screws to avoid these problems that can occur. So I put the same example with both techniques, with both results, but one ended with absolute stability and no callus, and the other one ended by relative stability and massive callus formation, and both function outcome are okay. So another case. It is 16 سنة, 16 years old patient with a fracture of... Now, yes.
I'd like to go back to the final slide. Okay. This is relative stability.
Yes.
And in our MIPO applied plate, this was a neutralization plate over
the compression screw.
Right. So this was absolute stability.
That's what I'm saying. We reach both. Yes, that's what I'm saying. That we reach both results. One with absolute stability and other with the relative stability, and we get the same result, exactly the same with the function. So a 32-year-old with that type of fracture, both bone forearm. Forget about open. It's open, but it's not just a puncture, so it is not going to affect our results. So, Dr. Abd-Elazim, how would you treat this fracture? Absolute stability, your plan is going for an absolute stability or relative stability?
For the radius fracture, I'll see this is a little bit of comminution. So I'll go this is for relative stability. For the ulna, I'm not sure this is significant comminution. If significant comminution, I'll go also for relative stability. But if it can reach absolute stability, I'll do absolute stability for this. I'm not sure this small fragment of the ulna is compromising stability or not. If it's compromised, I'll go also for
Dr. Abd-Hakim, I'm sorry for the interruption, but I see a lot of questions regarding the first two cases. So what do you think? Should we apply? Because people are getting confused about how did we do an absolute stability with a lag screw and a neutralization plate. And some others are asking about why did we cast the first case, and I think there is a bit of confusion about the first two cases.
So why that's how we do an absolute stability. Absolute stability means we need a compression. So how to achieve compression? We have several ways to
understand that the plate is a neutralization plate
for
an absolute stability with a lag screw.
That's what's no Stan. Leg screw summary and take home message from the first case. Leg screw for compression. Then we put a neutralization plate.
Two cases. Some people were asking why did we do a cast?
Just to protect our fixation for because neutralization plate is not as rigid as nailing. Mechanically, nailing is much better, as you have said. That's one advantage of nail. No, we don't need a cast here. Definitely, we don't need a cast. That's a very short cast, but we don't need it, of course. Maybe it was for soft tissue, just for soft tissue relaxation or soft tissue healing. That's it. It has no function here.
May I add something? These two example is an excellent example for surgeon decision. So it are similar fractures. Exactly. One surgeon decided to go for nail with relative stability and applied the technique proper and to get healing. The other surgeons applied interfragmentary compression, neutralization plate with absolute stability and get union. So it is the problem, the issue of just choose the proper technique and the proper principles. If you can apply either principle, just to go and apply any one of them correct.
Yes. So let's go to this case, the postbone forearm case.
I'd like to comment on this case.
Which one?
And the forearm case.
Okay.
And looking at the comments coming on the chat room, there's some people are mixing up principles. Mm-hmm. Because we consider both bone fractures of the forearm intra-articular fractures because they are involved in pronation and supination over an inferior and a superior ulnar joint. They believe that it can only be treated by absolute stability. No, it has to be anatomically reduced. Anatomic reduction, okay, is a must in both bones forearm. However, the type of stability achieved depends on the fracture pattern. If you have a small, I don't know if you can see my pointer, probably you can. If you have small fragments like those, you will probably try to buttress them, and maybe if you're lucky enough to have interfragmentary compression, interfragmentary screws, even if it's a mini screw, but it is the principle of anatomical reduction, and if achievable, it is absolute stability. If not achievable, relative stability by a buttress plate is equally accepted.
Tamam, exactly. So any diaphyseal fracture, whether it is a forearm fracture is less forgiving than any diaphyseal fracture. It is less forgiving than tibia and less forgiving than the femur. So that's why we needed to be. We need an open reduction for it. We usually don't use. Do you put nailing here? Do you put a nail here?
Nails are not standard and are not advised by AO. However, because of the unique movement of pronation and supination,
Exactly.
Cannot accept but anatomical reduction. Okay?
Exactly.
We cannot actually, we don't treat it as any shaft fracture. We consider it as an articular fracture.
Exactly. So we need here an anatomical reduction as much as we can, and this can be achieved whether the healing will be absolute stability or relative stability. That depends on the fracture configuration. So that's another issue. So here, let's go on here. What we have, what happened. So that was the plating, both open reduction and open reduction and internal fixation by plate. And as you can see that for the radius they did a bridge plate, they did a bridging, and for the ulna they did an absolute stability for the ulna, and that's because of the ulna. On the radius there is a big fragment that didn't they bridge it and they made an absolute stability, but the alignment and everything is well done. Any comment on this fixation?
Yes, I don't know if this is just stretching from the projection of the X-ray, but I cannot see a radial go on the anteroposterior view. On the anteroposterior view, I should see a radial bow to restore pronation and supination. Because these two bones are parallel, that means it's a supinated view.
Yeah. Okay. This is supinated view from the ulnar styloid.
This is the radial ulnar joint. Yes.
Yeah. This is supination view.
Yeah.
Okay.
Let's see
let's see what
by the way, somebody's asking 12 hours in a puncture compound is right. If it was a clean, it's a fracture from within, you are relatively safe to fix it within the first, even up to 24 hours.
Yeah, for open fracture grade 1 puncture, I will go if I can go and fix it after the debridement and fix it at once with a plate, and I don't worry about the infection if I do it within the 24 hours. Any other option? Any other opinion? Dr. Osama.
I think if a fracture is forearm, if it's open fracture, you have to go and fix it.
And I am trying to be more simple and don't want to go to a lot of debates now. عشان لو فتحنا open fractures now and how to fix and when to fix, it will be so for open fracture grade 1 puncture.
Our next coming webinar on Saturday the 15th. Okay.
Exactly. Yeah.
On Friday the 15th, we have a whole seminar on open fractures and soft tissue management with fractures.
Okay. And it will be a global, so it will not be for just.
It's on the global platform of AO.
Exactly, on the global platform. So let's continue our case. So that's after 6 months, fully united, and as you can see that for the ulna there is no callus formation, so that means that's a direct healing without callus formation. That's absolute stability. And for the radius, we can see that there is some callus formation on the medial side, and we call it indirect reduction and direct healing with callus formation. I think it is obvious here, very obvious, the callus.
Yep.
So for arm fracture, because of their low tolerance of any deformity, should be treated with the principle of articular fractures, as Dr. Ashraf said. Preoperative planning is essential for patient for better outcome. There is an importance in restoration of anatomical limb axis and the fracture configuration. Usually, which type of stability we are going to use here. So exactly as we have said with the panel, according to the fracture type, the stability will be
there are
chosen.
questions about the autologous bone grafting, the primary bone grafting for forearm fractures.
I will not do a primary bone graft. I don't need to do primary bone grafting for any fracture, not just the open forearm.
I think the questions are not to do primary bone grafting unless it's an union or a delayed union in most cases.
Unless you have bone loss.
If you have a bone loss, would you do it primarily?
Depends if
Bone
it's
loss. Bone loss means that there is a very severe an open fracture, which is a massive open fracture. So for a bone loss, I would not do it primarily, not for the first stage.
Yeah, I quite agree.
Okay, so let's proceed to another case, another scenario of postbone forearm. He is 16. There is a epiphysis still موجود, and it is a little bit proximal. So it has a fracture on both sides, as you can see, both bone fracture. So here is a question: what do you think about the mechanism of injury here? As you can see on the ulnar side, there is a small butterfly. On the radial side, there is no butterfly. It is simple fracture. So usually this is a bending fracture, and because of the butterflies, it is associated with a torsion on the radial side. So it is a bending with some torsion. And the second question will be, what about the interosseous membrane here? Usually, when you have a good relation proximally and distal between radius and ulnar, that means that the interosseous membrane is still intact. Usually, but just injury at the level of the fracture, but above and below it is still intact. And definitely, we need to check joint above and joint below, and we have to check about the distal and proximal radioulnar joint. Ashraf, do you need to check anything else if you have a forearm fracture?
Well, in this forearm fracture, I'll be quite interested to test the anterior interosseous nerve. The anterior interosseous nerve. It's very important because probably you will be injured, and you have a very weak. You're going to have a very weak flexor pollicis longus, and you better pick this up preoperatively and tell the patient before you want to operate on it.
That's because of the level of the fracture, or any type of fracture.
Because of the level of the fracture.
Oh, the level of the fracture. Okay, excellent. Yeah. So and here we need to check if there is compartmental or impending compartmental, because sometimes there is some bleeding from vessels here, and sometimes you get a lot of compartmental syndrome here. So next question will be, what sort of stability is needed here?
I think here you need absolute stability for the radius, because this is a simple fraction. This is actually what I'm going to start with. Start with the simple one, get absolute stability with plate, I would say dynamic compression plate. For the ulna, I would go for a relative stability.
who else is فاتح مين؟
we can go for we can go for absolute stability for both bone. As you see here, we have a wedge fracture for the ulna, and this wedge can be reduced anatomically and fixed by single or two leg screws together with the plate. This is going to be a neutralization plate, so absolute stability for the ulna. And also I agree with Dr. Ahmed Khuleif that I'm going to begin with the radius, absolute stability and compression plate.
I agree.
The principle is you always start with the less comminuted side, because this will be a better guide to length and reduction. You always start with the less comminuted side.
Let's assume that I am not going to be able to do an absolute stability for the ulna. And for the ulna, what type of screw are you going to use for that small fragment? Mahmoud.
I didn't understand. How you are
how are you going to fix that small butterfly?
Using the relative stability, you mean, or using the absolute stability?
لو انت absolute stability.
If it is absolute stability, leg screws.
ايوه
3.5 leg screws.
3.5.
Yeah.
And I want to use 3.5 if I'm going to do an absolute stability here. Dr. Mahmoud, Dr. Abd Hakim.
I'm not sure. When I open first I want to respect soft tissue.
Exactly. Yeah.
If I found I will devitalize this fragment when I fix it, I'll go for relative stability straight away.
Okay.
But if I found it is in place, I can manipulate it without disturbing the soft tissue. According to the size, if the size allows 3.5 screws, I will put it, or I'll go for 2.7.
2.7 scale.
Yeah. 2.7 is rare now. We can use 2.5 or 2.4.
2.4. Yes. That's what I'm saying. Is يعني of screws and plates. So don't use. You can combine several screw sizes for one fracture. It is not. I'm going to open 3.5 plates, so I have to use these. That doesn't work. Use 2.4, 2. Whatever it is, mini plate, mini screws if needed. I usually open as a mini set and this other sets with you. For example, when I go for a humeral fracture and I put a broad DCP, I usually fix the leg screw with a 3.5 screw. I don't use a big smart كبير. I don't use 4.5 for a leg screw. I usually use 0.5.
I agree that everything should be available.
Yes, that's.
But if we found this fragment is still attached to the distal fragment,
and you can fix it, so go for absolutely. Exactly.
Yeah, we can use the 3.5. If we found that this is still a small fragment and we have the fear that the 3.5 millimeter screw can break the fragment, I will go for a more narrow diameter like 2.7.
Exactly. That's what I'm saying. That's what we have to agree upon. So what happened? That's what happened. That they did 2 bridging plate for locked 2 bridging locked plate for the postbone 4R. And عايز بقى, what do you expect to happen here? Will it unite? Will it not? دكتور أسامة معانا ولا ماشي ولا زعل منك؟ زعلته يا أشرف؟
لا ما حصلش يا باشا. دكتور
طب هو فينه؟
استنى بس مش عارف.
اوعى تكون عملت له ميوت.
لا
أسامة ميوتد.
يعني عامل ميوتد للدكتور أسامة وعامل انميوت لبدران.
حازم معانا كمان؟
حازم موجود برضه؟
ولا الدكتور أسامة؟
لا الدكتور أسامة بيقول لك ميوت مي. الدكتور أسامة بيقول لك ميوت مي.
طب ازاي؟ ما لازم يعمل ويف ولا حاجه دي.
طيب ايه رايكم هنا؟ طيب اللي اتعمل مبدئيا كده، ايه رايكم في القصه دي؟
It's not an ideal. You will be afraid of implant failure or non-union.
بالنسبه لانهي فيهم؟ It's not ideal في ايه؟
الراديوس فيها جاب، فهي he didn't reach absolute stability axial compression.
هنا he did not do any absolute compression for both fractures. So هنا عمل bilateral bridging يعني بطرس ما عملش.
These are locking screw.
locked دي معناه ان هو very stiff.
Like internal fixator.
That's very stiff fracture. That's very stiff fixation.
Well, I think that things will go in a better way for the ulna because it is still a comminuted fracture and he applied only relative stability. So it can work for the ulna. But for the radius, I have the fear that it may not unite because as you said that it's too stiff and there is still a small gaps present. So it might end with non-union. I don't
دكتور
know.
أشرف
أسامة رجع لنا خلاص.
أشرف أنا شايف دكتور سعيد الثاني موجود.
بيقول لك تو ريجيد امبلانت.
أشرف أنا شايف دكتور سعيد الثاني، ما تقولي دخله معانا لو يحب.
unmute دكتور سعيد.
طب انت يا اسامه ايه رايك؟ دكتور سعيد اهو.
I see a the fracture site, and on the other hand, the fixation is too much. We have too many screws on each side on the ribs, 4 screws on each side. But we need long ribs to see reduction, the curve of the radius and the ulna as well.
دكتور سعيد ايه رايك؟
I think it's
كل سنه وانت طيب الاول.
وانت طيب الله يحفظكم اجمعين. I think it's too rigid, too stiff. This will lead to stress riser at the fracture, especially with the gap. Also, it is expensive to use locking plate. It's unnecessarily. I think this is unfortunately will not heal.
Okay. Any other طب ما انا can I ask you يعني احنا الالنا it is هو long plate is for the ulna and short plate for the if I'm going to you if I'm going خدوا معايا كده الفكره كده ومش واحده if I'm going to do a minimal invasive في التibia okay and I'm going to slice a plate في fracture زي دوت I'm going to accept that gap. I can end with that gap for minimal for a maple fixation. I will end with that gap. Why not to consider that as a maple fixation? بس هو مش بيبو يعني هو فتح وعمل.
No. If you will do maple, you will use a longer plate. You will not put the 2 screws near the fracture site to make the construct less stiff.
Okay.
And you put the screws away. So.
طب تشيل انهي مسامير لو انت هتعملها ميبو تشيل انهي مسامير وتسيب انهي مسامير؟
I'll remove the 2 screws near the fracture site and I increase the length of the plate 2 screws on each side. 2 hole each side. I put 1 screw in each hole on each side.
Okay. طب السؤال الثاني how much gap would you accept?
What you are aiming for. If you are aiming to absolute stability.
ده مش absolute stability هو الوضع ان هو he was not aiming to absolute stability from the start. So how much gap is accepted?
Professor Abdullah, if you allow me to talk here.
Yeah, please.
If you look at this is a simple fracture.
Yes.
So it's almost like a transverse or oblique.
Exactly.
So it's not accumulated. So more than 2% the displacement. You're gonna go to the gray zone. More than 10% displacement from the diameter, you're talking about non-union here. Okay. So if you want to do a relative stability here, you need to reduce the number of the screws to allow the blade to flex and allow the 2 edges to compress to each other. Otherwise, they will not heal.
So the problem here is it is a too stiff plate.
Yes.
Reconstruct.
And the bad reduction.
Okay.
And
so that's
not anatomic reduction.
Not anatomic reduction. It's
gap.
Not compressed area.
Let's say
okay.
not well reduced. There's a gap in the fracture site.
I think the problem is wrong applying the principles because he mixes the principles of relative stability with absolute stability. If he wants absolute stability, he has to compress the fracture site. If he wants to relative stability, he has to make construct less stiff.
Yes. So that's the post-op X-ray, as you can see. And عمل في الألنا he did bridging up because of fragment, and for the radius, what happens? There is a gap, very obvious, and كلنا even if it heal, even if it's going to heal, if it so whatever, that's not the proper principle applied here. That's not ideal how to apply it. So it is not. He has a good luck. It healed exactly. It healed, but that's good luck for him. So when we have this fracture and a simple fracture, and we go for an open reduction, we need to have an absolute stability. We need a compression. And to apply a lock the plate, lock the plate, as Dr. Saeed said, it is very expensive to have this plate with all these screws. It's too expensive. Al fadi, we don't need it. So the principle here was not well
applied,
well done, well applied. And as you have seen ده بعد تشوف 200 مش عارف ايه اسبوع هو لحم. It did unite, but that's not
like 5 years.
That's like 5 years. Yeah. So that's don't take the message here that's improper application of the principle. That's why I put it, unless it's united, but that's improper application of the principle. So simple fracture of the radius needs an absolute stability. Ulna with a small butterfly, better to be treated with the relative stability concept. Hena intact biology and stability maybe helps a fracture hip because the biology is young adult 16 سنة. Maybe that's also the reason why it did unite and didn't break. So that's another issue. But the main message is that for a simple fracture of the radius need absolute stability. Any question هنا أشرف؟ في أي حاجة؟
No.
في أي تعليقات؟ أي comments هنا؟
لا, we're fine.
Okay. I thought, Ashraf, do we have more time, Ashraf?
I think I think we've already been 2 hours, and we're planned for 1 hour 40. So I think this is enough. I'd like to thank all presenters, Professor Ahmed Khalif, Professor Hakim Abdullah, Professor Saeed Tani for joining us, and Professor Azhar Taban for these very interesting cases he has chosen for us. And I would also like to invite you all to our AO trauma webinar. Our AO trauma webinar will be on the 15th of May, 9 p.m. as well. We will me and Professor Mahmoud Abdul-Karim, we will be presenting controversies in open fractures and soft tissue management, and it's a very interesting case-based discussion. I hope you can all join us. It's designed for 1,000 attendees, and we have right now 660 registered. So hurry up and register. It's on the AO website. And good luck to all. Thank you very much, everybody, for attending. I hope this was useful. And we're going to be doing this event on a weekly basis, and we'll keep you posted. Follow us on Facebook, and we will WhatsApp, and we will establish a method of communication. Thank you very much for everybody.
Thank you all.
Thank you.